Good morning, everyone, and welcome to the San Francisco Interfaith Council's weekly online briefing for faith leaders. This session will center around the implications of forthcoming COVID-19 vaccination. It is hosted by the San Francisco Interfaith Council and supported by the Joint Information Center of the San Francisco COVID Command Center. Housekeeping. Audio, video, and chat will be monitored and recorded for record-keeping, training, and quality assurance. By default, all participants will be muted and video turned off to minimize distractions. To submit a question or comment, select the chat button at the bottom of your screen and send a message to Q&A. They will be shared with the speakers after the meeting for response. Thank you. Due to widespread COVID-19 infection rates, the state has now moved San Francisco into the most restrictive tier, purple. In accordance with the state order, there are many restrictions on indoor activities, including the temporary closure of indoor worship services, gyms, movie theaters, museums, and indoor retail capacity is limited to 25%. Additionally, San Franciscans must follow the state's limited stay-at-home order, which includes that you can go outside on your own or with people that you live with. You can go to an essential job. Avoid being around people from outside your household between 10 p.m. and 5 a.m. You can still get food takeout after 10 p.m. and go to grocery stores and pharmacies. Our actions now will shape how San Francisco emerges from this pandemic. Together, we are resilient. Learn more at sf.gov/limited-stay-home. Get tested, San Francisco. You can save lives and stop the spread of COVID-19 by getting tested through your healthcare provider. If you have symptoms or have been exposed to COVID-19 but don't have health insurance or can't get tested through your provider, visit sf.gov/gettestedsf or call 311 for information on getting tested at a city-run testing location. At this time, I'd like to hand the floor over to the Executive Director of the San Francisco Interfaith Council, Michael Pappas. Michael, the floor is yours.
Thank you, Elisa, and thank you to our colleagues at the COVID Command Center's Joint Information Center Virtual Outreach Team. Your longstanding commitment to this program, which this is the 33rd, is really testimony to the city's commitment to making sure that our city's faith leaders are receiving the information they need to make important decisions on behalf of those with whom they've been entrusted. So we are very grateful. Good morning, I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this morning's online briefing for faith leaders. To stem the tide of spiking coronavirus cases, which are stressing hospitals, their ICU bed and healthcare worker capacity, the Bay Area as a region has entered into yet another restrictive stay-at-home order. Realizing that social distancing, mask wearing, and proper sanitizing are critical precautions to keep the virus at bay, the greater hope for more decisively fighting the coronavirus is the emergence of a vaccine, which appears to be on the horizon. With that hope is also uncertainty and legitimate questions. How does a vaccine figure into our city's greater equation for responding to the pandemic? With so many different vaccines being touted by the media, what options are being considered for San Francisco and why? When will it arrive on the scene? Will it be safe? Will it be more than one dose? From a prioritization and equity perspective, who will get it first? Will it be mandatory? Will a vaccine mean that San Franciscans can expect a return to normalcy anytime soon? This week's online briefing for faith leaders, hosted by the San Francisco Interfaith Council and supported by the COVID Command Center's Joint Information Center Virtual Outreach Team, welcomes Associate Professor in the Department of Emergency Medicine and affiliate faculty for the Institute for Global Health Sciences at UCSF, Dr. Andrea Tenner, to address this timely and critical issue and respond to these questions and those of leaders of our city's faith-based social service agencies. Without further ado, I would like at this time to welcome the chairman of the board of the San Francisco Interfaith Council, friend and colleague, Kaushik Roy, who is also the executive director of the Shanti Project.
Thank you very much, Michael. Good morning to you and to all of you that are joining us virtually. On behalf of the Board of Directors, of course, we're very grateful to be with you again this morning, as we have so many times over the last 9 or 10 months. I think most, if not just about every faith tradition in some way or another, addresses the importance of hope to our species. And in one form or another, all faith traditions, I believe, will say something like, you can take away anything from a person, but never take away their hope, because their hope may be all they have. And I know I think of this when I feel like we are in very dark times, which over the last couple of weeks, to be very transparent, I have been, and I suspect some of you as well. But I think one of the few things that keep us going is that hope that we've been hearing about in the form of a vaccine, which legitimately looks like might be available to some folks, at least here in the very near future. And so I want to give a special thank you also to Dr. Tenner. As Michael mentioned, with my Shanti hat on, we work closely with the Emergency Operations Center. And so we get a unique insight into just what you and your medical colleagues are doing and have been doing, and it's really humbling. So I want to express my gratitude for your time here this morning, as well as what you've been doing all along. For those of you who are joining us for the first time, I want to give a special welcome to you. At the beginning of every interfaith meeting or gathering, there is an interfaith statement we like to read. It's just a momentary way to make ourselves present and remind ourselves why we're gathered all here together. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we're invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other so that we might better understand the multiplicity of faith traditions in our city and in our world. Good morning, everybody.
Thank you, Kaushik, and thank you for your continued leadership. The San Francisco Zen Center has historically in our city been a beacon of hope and a beacon of light and a beacon of spirituality for not just the Buddhist tradition, but for the greater city. We are grateful for them. And this morning, we are grateful that the central abbot of the San Francisco Zen Center, Rinso Ed Sadizan, is with us to lead us in a reflective moment.
Thank you very much, Michael, and good morning, everyone. I bring greetings and well wishes from the San Francisco Zen Center to you this morning. On or near December 8th, Buddhists around the world celebrate Buddha's enlightenment. At the San Francisco Zen Center, we had a ceremony last Saturday morning to celebrate this joyous occasion. To quote from my teacher, Suzuki Roshi, from his book, Zen Mind, Beginner's Mind, when Buddha attained enlightenment under the Bo tree, he said, "It is wonderful to see Buddha nature in everything and in each individual." We recognize that each of us can be fully awake to the joys and sorrows of this life. We affirm that every life is precious. We become aware of how interconnected we are. In this time of COVID-19 pandemic, this awareness can help us face the difficulties and celebrate the moments of connection. Knowing the value of each life, we put our best effort into cherishing life, protecting life, caring for others, listening deeply, and responding from this sense of interbeing. Let us please have a moment of silence together. I will begin with 3 bells and end with a single bell. May our intention equally extend to every being and place with the true merit of Buddha's way. Thank you all very much.
Thank you, Rinzo Edsadazan, Central Abbot of the San Francisco Zen Center, for grounding us in this reflective moment. It is a great privilege for the San Francisco Interfaith Council and this series to welcome today Dr. Andrea Tenner, who is the Associate Professor in the Department of Emergency Medicine and affiliate faculty for the Institute for Global Health Sciences at UCSF. Dr. Tenner has dedicated her career to building resilient health systems and improving access to quality emergency care for patients in low and middle income countries. So without further ado, we welcome Dr. Tenner and we look forward to your presentation.
Thank you so much. Really appreciate it. I appreciate the opportunity to be here with you all this morning. Thank you so much for the invite. Please give me just 1 minute. I'm going to get my slides up here, which is always an adventure. So let me get that set up. All right. Are you all able to see my slides here?
Yes, all is good.
Thank you. So thank you again so much for inviting me to come speak to you today on this topic that I think is kind of is forefront on a lot of our minds right now. And I think to expand a little bit on what was mentioned earlier around hope, I think, I would say not only is hope something that is present within all of us, but I think it's also our greatest strength. And it's what keeps us going. It's what keeps that my fellow healthcare workers and I going to work every day. It's what keeps us in the COVID command center. It's what keeps us motivated. We are in one of what right now is one of our worst surges. And we are all concerned about what is going to happen. We're seeing numbers that we have not seen previously. And that's scary for everybody. It's scary for the communities. It's scary for all of us that have been watching these numbers very closely for the past 9 or 10 months. And I think it's scary for us as for humanity as a whole right now. But we have some hope on the horizon. And I think that's the thing that keeps us moving forward. And so I wanted to talk to you guys a little bit about what what we know so far about the vaccine and where we are in the planning for this. So just a quick overview of, there are 2 vaccines right now. There's about 6 that are finishing up their final trials, but 2 that have reached a point where they can apply for an emergency use authorization, or an EUA, from the Food and Drug Administration. So both of them are actually they had much higher efficacies than we thought that they might, which is very encouraging. So the first one that has just been submitted is a 95% efficacy, and the second one is really kind of more rounding, 94.5%. So very close and very effective vaccines, which is really exciting. To give a perspective, the flu vaccine is usually somewhere around 50 to 60% effective. So this kind of efficacy level is really exciting for us. Both of them had a large number of patients. So the first one that was been submitted was greater than 43,000 patients involved in the trials, and the second had over 30,000 patients. The way that they look at these trials is how many patients, so you give the vaccine to some people and you give a placebo, meaning usually it's like a saline injection or water injection essentially, to others. And then you look and see, is the difference in their infection rate higher, or is it impacted, sorry, in the vaccine group. So if you look, the first vaccine, in placebo, so in the patients who did not get the actual vaccine, they had 162 cases, 9 of which were severe. In those who got the vaccine, only 8 people got infected with COVID at all, and only 1 severe. The second vaccine that just was submitted, 90 people got COVID in that case, in those in the placebo group. 11 of those were severe, and then in the vaccinated group, only 5 got COVID and 0 were severe. The numbers were a little bit smaller in the second vaccine group by the time they reached their endpoint. And just so that you're aware, the endpoints are calculated for these types of studies. They look at a certain number. It's a statistical analysis that frankly is above my pay grade, but what they do is they look at those, they calculate out how many people do they think need to get COVID in those studies to say that you had sufficient exposure to COVID to be able to say one way or another if the vaccine helped. So as an example, when we were working on the Ebola vaccine, you could give the Ebola vaccine to a bunch of people in San Francisco and say that it had 100% efficacy, but if people weren't exposed to Ebola, which they were not here, then that doesn't mean anything in the study. So you need to have a certain amount of people to know that you were actually, people had exposure and that the study actually means something. That was how they calculated this out. And they were not exposing people to COVID. This was just people going about their daily lives. And then they were registering who might have gotten sick and who didn't. So those numbers are very encouraging, that there does seem to be good efficacy from both of these vaccines. There were no significant safety concerns. That's something else that people look for with these vaccine studies, to make sure that, that we do expect some side effects. As many of you know, when you get your flu shot or you get a tetanus shot, you can have some pain at the site. You may feel a little run down. Sometimes people can get a low-grade fever. Sometimes people can get body aches or sort of generally feel like they're starting to come down with something, and then that goes away. We don't know yet, because all of the data that we have, that we can see as the public, is been in press reports. But the FDA is looking at the actual data, all of the individual data for these vaccine studies, to see if this looks like it was safe or not. But from what we've heard, there are no significant safety concerns with this, which is great. Both of these, so Operation Warp Speed, which many of you guys have heard about in the news, what the idea was to try to get a vaccine as quickly as possible. But we, I think in the US, are very fortunate to have the FDA, which is one of the toughest regulatory boards in the world for drugs and therapeutics. And so what they were able to do with this vaccine was, rather than, usually these vaccine trials are conducted in phases and the data is published in between. What they did is they sort of stacked the phases together, and they actually overlapped some of the phases. So there were a lot of vaccines that were attempted but didn't make it out of phase 1 or phase 2. And so those have not gone on to these phase 3 trials. So there's 6 vaccines right now that are in the phase 3 trials, and these 2 have completed and are up in front of the FDA for review. So for Operation Warp Speed, what they did is they also started production, which is also unheard of. It's a big gamble, because if your vaccine doesn't pass those phase 3 trials, then you have a bunch of vaccine that's not useful. But these companies had already started producing some vaccine. So the first vaccine has about 50 million. They're anticipating by the end of the year, so in the next few weeks, to have 50 million doses, but that is globally. So that is also going to the UK, it's coming to the US. And then the second vaccine anticipates having about 20 million doses for the US. They are both planning on ramping up production significantly in 2021. So to have between 500 to 1 billion doses by 2021. So, similar to the theme of the pandemic, production lines are always one of our challenges. This is kind of like the toilet paper crisis, but on a bigger scale. So we're trying to increase production to match the demand and to match the need. So it is coming, it just may take some time. So as I mentioned, both of those two vaccines are now under review at the FDA. The first vaccine should be reviewed this week. And they are pre-positioning some vaccine supplies in hospitals around the country. There are 7 hospitals in California that are getting pre-positioned supplies. San Francisco has 2 of those. So that is UCSF and ZSFG, the San Francisco General and UCSF's Parnassus campus. We, though, on the West Coast and in California have an extra layer of protection and review, which was set out by Governor Newsom around September. They decided they wanted to make sure that people felt safe getting the vaccine and that we had enough of a review around this. And there was some concern around the politics of the vaccine. So we set up an independent review board in California. Dr. Tomas Aragon, who is our current health officer, who was just actually appointed to lead the California Department of Public Health a couple of days ago. He is going to be on that committee, and that committee brings in vaccine experts to, again, review the data. And we in California have decided that we will not be giving out that vaccine until this second group has reviewed the vaccine and agrees with the FDA's findings. If the FDA issues the emergency use authorization, that the vaccine is safe to be disseminated out. And the states of Washington, Oregon, and Nevada have joined us in this. So essentially the West Coast will be doing a secondary review, and then we will start disseminating the vaccine if both of those bodies, the FDA and our group, have reviewed the data and feel that it is safe. So, as I mentioned, this is kind of like the toilet paper crisis on steroids. So we're trying to plan for the vaccine rollout as we have supply ready. So we anticipate this will be in 3 or 4 phases. Essentially, this first phase is really going to be our when we have a very limited supply of the vaccine. So, for example, California, the Bay Area. California and the Bay Area will be getting vaccine allocations. San Francisco will be receiving a little over 12,000 doses of the vaccine next week, of the first vaccine to be approved. Now, again, that will be the first vaccine to go to the FDA. That will be in storage here. We will be keeping it here. It's pre-positioned, but we will obviously not be vaccinating people until the full review has been completed and the vaccine's been deemed safe. So those first doses will go to the initial critical populations. This is determined by the California Department of Health and the CDC. So what they feel are the initial populations to be vaccinated are healthcare workers, and that means anybody who works in a healthcare setting where they come into contact with COVID. So that would be, obviously the doctors and nurses, but also the janitorial staff, food service workers, any of our essential workers that are working in high risk areas. And then also adults who live in skilled nursing facilities or residential care facilities for the elderly. So these are congregate settings where many of these patients have dementia, they have memory issues, they can't really comply with masking, they may wander, and it's a higher risk to those populations. They also tend to be in that vulnerable group that is more susceptible to death from COVID. So those are the 2 populations we anticipate in phase 1 to be rolled out. And part of the reason for the healthcare workers is obviously they are at significant risk from the exposure, but also even for healthcare workers who might not die from COVID, if you have a bunch of healthcare workers out, especially right now as we're starting to surge, if there are healthcare workers who are sick and can't come to work, that decreases the population of healthcare workers that are available to take care of people. And when you have a surge like what we're seeing right now in COVID cases, one, we may, as the hospitals start to get stretched, we worry that if we don't have enough staff, we can't give the care that we need to give for COVID patients. But also, if it happens to be my day to have a heart attack in the middle of a COVID surge, there isn't staff to take care of me either. And I might die from my heart attack when I wouldn't necessarily have died had this happened a year ago. So we really need to make sure that that healthcare workforce is ready and able to take care of all of the emergencies that can happen throughout this surge. As we start to get more doses available, what we then move into the next phases. The second phases, we haven't been given the specific prioritization, but we assume, and the discussions that we have heard, it will be the kind of non-healthcare but essential workers, people who live in congregate settings, people who are, so those would be people like in shelters, for example, people who are vulnerable to COVID, to death from COVID, or who are at higher risk of death from COVID. So people with comorbid health conditions. And then as we start to really reach that peak of vaccine availability, then we start opening it up to then the next tier, who's the next set of vulnerable populations, with the goal of, as we start to get that vaccine available, of making sure that everybody in San Francisco who wants the vaccine can get it. And that really is our goal as the COVID Command Center, is we want to make sure that everybody who wants the vaccine can get the vaccine, and that everybody has access to the vaccine. Because we are dealing with some limited resources as far as just the production schedule of the vaccine, we don't know how much vaccine we're going to necessarily be getting at what times. But our goal is to make sure that the process for prioritizing is as transparent as possible, and that people have a sense of where they fall in that prioritization scheme, so that they have a sense of maybe not exactly when they'll be getting the vaccine, but in the general scheme of things, where they fall in that. Again, this is trying to roll out as quickly as possible to get this vaccine out to as many people as possible as we can. So, as I mentioned, the prioritization is really mandated by the state. And this is actually a memo that they sent out to us. So it shows that phase 1A is those people at highest risk of exposure in healthcare or long-term care facility settings, and then residents of skilled nursing facilities, assisted living facilities, or long-term care facilities. Within that, there's a sub-prioritization, which is this recommendation B, and that is based on the type of facility you're in and the risk you're exposed to, or the risk you have based on your role, where the facility is located. Obviously, we want to make sure that hospitals in vulnerable neighborhoods or in settings where there's a great need, that we make sure that those staff are vaccinated and healthy and ready to deliver care as needed. And then individual attributes. So somebody who, say, is at higher risk, who may be a healthcare worker, but also themselves at higher risk of COVID, or works in a skilled nursing facility, or lives in a skilled nursing facility and is at higher risk. So there's a lot that's going into this. The California Department of Public Health has been mandating and giving us this information as it comes through, so that we have a sense for where the priority is. And I'll mention in a little bit how they're getting information to try to help determine this prioritization. So the doses will be allocated from the federal government. And so the federal government has the doses. They will give some to federal government entities, for example, the Veterans Administration, the Indian Health Services, federal prisons. Then there's also going to be an allocation from the federal government directly to pharmacies. There's a pharmacy program that is set up to help us vaccinate people in skilled nursing facilities and residential care facilities, to go out, because those, again, are highly vulnerable populations, and it helps those. These pharmacies are using their staff, they're storing the vaccine, bringing the vaccine to these populations, and really helping for this vulnerable group. The state of California then gets an allocation from the federal government, and some of that will go directly to state entities like the state hospitals or prisons. And then they will also allocate to multi-county entities. So this, for example, could be something like Kaiser, that has multiple facilities in different counties around the state. They can order vaccine directly from the state, store and handle that without our local health jurisdiction support. And then the final sort of allocation comes down to local healthcare facilities. And this is where we as COVID Command and the Department of Public Health will help to allocate these doses to individual facilities within San Francisco. And so this is where these other allocations will come in. So as I mentioned, this pharmacy partnership, so this is actually a federal partnership with these pharmacies to offer services to these highly vulnerable populations. So they will be scheduling and coordinating these on-site visits directly. They have they order the vaccines and have their own supplies. They provide the staff. They make sure that there's appropriate storage. So one of the things I forgot to mention about the vaccines is both of these two vaccines that are sort of the first ones coming out require very specific storage. So one of them, the first one, requires ultra low temperatures. So specialized freezers that to store these vaccines that many facilities do not have. And actually in San Francisco, when we first heard about this, we also took a little bit of a gamble, but we did not want to, we didn't at that time have, I think we only had 1 or 2 facilities that had any kind of ultra low temperature storage. So we purchased 3 large freezers that can manage these temperatures. So we have enough storage within the city for 600,000 doses. So we wanted to make sure that we had that space. Several other counties around us do not have that storage, and so we're trying to work collectively to try to help support people that need that storage as well. And the second dose, the second vaccine, needs freezing temperature. So not ultra low special freezers, but our usual pharmaceutical freezers. But most vaccine just require refrigeration. So this is also new. This is an added layer of complexity, but these pharmacies are also helping with that for the storage for the vaccine for these skilled nursing facilities and long-term care facilities. They will also go on site and administer and then enter that information into the state tracking system. California Department of Public Health is also helping to support this as we're all kind of working together. We keep joking that we are building the plane as we're flying it, but we are really working collaboratively to try to make sure that we have dotted all our I's and crossed all our T's, and we've thought through the different logistical elements of this unprecedented effort. So I mentioned already the Scientific Safety Review Work Group, and these are people who are well known for their immunization, public health, or other subject matter expertise that is around vaccines, and they're pulled in to review this data. We also have a group that's helping to draft guidelines, and so they are giving us guidelines as soon as they can get them drafted. And then we have a team here that is gathering all that information and helping to implement and disseminate that information out. They also have a community advisory vaccine committee, and this, as I'm sure you can imagine, whenever you are prioritizing something that is potentially life-saving, there's lots of concerns around equity and how are you, what is that prioritization scheme? There are tough decisions that have to be made, but ensuring that that is made with multiple different people looking at it from multiple different perspectives, and making sure that there's an equity lens at that, within that evaluation. So they have this committee is helping them with that. And then they're also helping to coordinate COVID vaccine provider enrollment, ordering and management. As you would imagine, this is a scarce resource. It's a resource that has the potential to be highly in demand. So it will be, the vaccine itself will be tracked very closely. And because it has such stringent storage requirements, it is actually very easy for this to, for the vaccine to be inactivated or to be wasted if it's not handled properly. So there's a lot of work going on around the vaccine handling and making sure that we are not wasting vaccine from both our city and county level and also from the state level. And then also, we're going to be ordering hundreds of thousands of doses of this and managing it, and then making sure that everybody's getting vaccinated. And as I'll mention later, the vaccination itself is a bit complicated. So tracking that and making sure that we are rolling out this vaccination in a way that is efficient and effective to all of our fellow humans that need to get this vaccine. So some of the challenges that I briefly touched on, but the vaccine characteristics themselves make this a bit challenging. This is a newer type of vaccine. It requires special storage, as I mentioned. It also requires 2 doses, and those doses need to be 3 to 4 weeks apart. So that in and of itself, you know, if we say there are 850,000 people in San Francisco, we're going to have to give out 1.7 million doses of vaccine because each person will have to get it twice. Now, this 3 to 4 weeks apart is important because it's a minimum date, not a maximum date. So what that means is you need to give your body some time to respond to the first vaccine dose. And then we give it essentially a booster. And that booster is kind of a reminder. So the first vaccine dose tells the body, hey, there's something that is foreign here. We need to attack it. And we need to learn how to attack it quickly. The second dose is reintroducing that same material and basically giving the body a trial run. So the body can recognize it and then say, oh yeah, this is that thing we saw before that we need to attack. And it can ramp up the immune response. So it's important to have both of those, because if you get the first dose and you don't get the second, then your body might not respond as quickly as it needs to really mitigate, to really stop the spread of COVID within your body. But that second dose it needs to be at least 3 to 4 weeks to give your body some time to adjust to the first dose. But if it's at 5 or 6 weeks, that's okay. Your body will still respond to it. It's just if it were at 2 weeks, for example, it might not respond appropriately to that second dose. So we're having to navigate that and try to make sure that we can get people vaccinated as quickly as we can, but also making sure that, you know, that people aren't coming in before those 3 to 4 weeks. The other thing is the distribution. So we are not entirely sure how much vaccine will be allocated and when, because it comes as the production comes. So as it's being produced, it's going to be shipped out. Yesterday, the CDPH sent us a sort of mind-numbing schedule for how they're anticipating sending this vaccine out. I really have a lot of respect and sympathy for our colleagues at the California Department of Public Health, because they are really working around the clock to try to organize all of the vaccine throughout the state. And so this calendar is really trying to, for the allocations that we know are going to be coming, anticipating when do you need to order them, when do they come out, but we don't necessarily know how much we'll be getting. So that's something that we're trying to be ready for and plan around. The other thing that is absolutely essential, as I mentioned before, is making sure that there's transparency in this prioritization structure. Anytime we have to limit a resource, there are challenges, and this one is sort of self-limited by the distribution. So making sure that as it's coming in, that we're following that prioritization structure, but also that the community knows what that prioritization structure means and where they fall within that. And the messaging has to be clear and widespread, which is part of the reason I'm so excited to be here with you guys today, because I think the more people that know about this and can help get this information out, the better. The last thing that we want is for any community to feel like they are not, they're being overlooked, or they're being unfairly treated within the prioritization structure, or that somehow, that they were skipped over. So that in my mind would be a huge failure on our part. And so we are trying very hard to make sure that everybody understands this, and that we're developing a community engagement group to try to help us get information back from the community. So if things like that, if those perceptions are out there, we can, 1, investigate them, and 2, make sure that those are addressed. And then the final thing is more of a technical issue, but really the data management around this. We need to make sure, so you can't get a dose of vaccine 1 and then get a second dose of vaccine 2. They has to be the same vaccine doses, which means we're going to have to track who gets what vaccine. So that in and of itself is challenging. And we need to have enough information that we record on the first vaccine administration to make sure that when that person comes back, that they get the appropriate dose on the second round. But also making sure that they remember to come back, and that we remind them to come back, and that they know how to access that to come back. The other thing that we are trying to balance is we recognize that in several of our communities are very leery about data tracking with good reason. So trying to make sure that we have the data that we need to be able to make sure they get the appropriate dose on the second round, but not more than that, and not anything that that makes people nervous about, other nefarious ways the data might be used. So making sure that we are getting that information out there and that we're being very mindful of our community needs. Some of the strategies we're working with to try to plan for this, we really are trying to plan to hit a moving target, and this is really unprecedented. So there's not, this is a lot of brainstorming and trying to come up with this. There's not, the older person in the room who did this before that we can ask questions to. So we're really trying to tap into everybody's areas of expertise. That's part of the reason that I'm here, because I've had, I've worked in areas like this in low resource settings, and have had to think through how to be scrappy and how to be equitable at the same time. We also have some experts who, we actually have somebody on our team who he was in charge of a vaccination program in Mexico that was able to ensure universal vaccination of children for measles vaccines within 2 years. So he has experience at rolling out vaccines quickly. So we're very fortunate to have expertise like that in the room. But that's really one of our main strategies. There's a lot of unknowns, and we're getting information as it's coming in, but we're moving very quickly on this. And so our goal is to make sure that we have the right people in the room so that as this information comes in, we're able to take it, process it, and disseminate that out and apply it. So the main areas that we really see that are these kind of buckets of strategy that we need to plan around are the storage. So we did act very quickly to getting that vaccine storage. That was one of the things I was losing sleep about at night. And when the day we got our vaccine freezers delivered, we found out that there was already an 8-week waiting period for those who were ordering them at that time. So we were very lucky that we were able to be on top of that early. The distribution plan, obviously this is a complicated vaccine for the storage needs. And so thinking about how can we make sure that we are maintaining what we call the cold chain, or those temperatures, as we're moving vaccine through, and that we're making sure that the appropriate groups within the city that can provide vaccines are getting the vaccines. Thinking about our partners. So this really is a huge effort. Vaccine providers have to be registered within the state. So we've worked with our hospitals, skilled nursing facilities, other healthcare facilities to make sure that they're registered within the state. And then also working on how do we coordinate that so that hospitals, that clinics are able to vaccinate their members when we have vaccines available. And then thinking about the people that might fall through the cracks or maybe aren't a member of one of those clinics or hospitals, or can't get there because of some barrier to them being able to get out to get vaccine. So making sure that we are looking for all of those populations and making sure that they have access to vaccine. Communication, as I mentioned before, is really, really important. We really want to be able to make sure that people, as we are getting information in, that we're helping to disseminate some of that information out, but also making sure, because as I know everyone experienced early on in the crisis, information comes in so quickly and changes rapidly. And there are some things that may change as we learn more about the characteristics of the vaccine or best practices on disseminating out the vaccine. So making sure that we are communicating as much as we can, but also trying very hard not to confuse people, and trying to be clear about things that may change, that we don't, that are just, we're early in the process and it might change later on as we get more information. The organization, so just the infrastructure to support all of those vaccines and making sure that people are getting the right one when they come back the second time. And how do we monitor? We also want to make sure that we're monitoring people for side effects. And also, one of the things we don't know about this vaccine is how long it will last for. There is a lot of hope that it will actually last a longer period of time, and that with the efficacy of the vaccine, that all those things are really promising. But until we have people who have been vaccinated for a longer period of time, we won't know for sure. So we really need to be able to monitor people to see if, are people who were vaccinated coming back with COVID? Because if that's the case, then we need more information. So really making sure that we are keeping a close eye on that, and that and that we're taking care of all of our people. And then finally, this access. We're one of the things we are planning for as COVID Command is how do we fill the gaps in the vaccination strategy? We have hospitals and clinics that know how to do this, and we're working to try to coordinate them so that we can make sure that we cover as much of San Francisco as possible. But we know that there are some people that can't access those clinics or hospitals, or might be members but can't get there. Or, for example, our blind community may have issues. It's hard to get out and to maintain social distance. And so we want to make sure that they feel comfortable and that we address the issues that they might have, for example, around coming out to get COVID vaccine. So we're trying to take all of those different populations into consideration and figure out how we can make sure that anyone that wants the vaccine can get it. So this really is an all hands on deck activity. We really do see this as our ticket out of the crisis. And again, we're waiting to see what the data looks like, what the actual data looks like, but from the information that has been shared, it sounds very promising. So we are gonna need to come together, not only as the COVID Command Center or the Department of Public Health, but with all of our healthcare partners and also all of our community partners. And really, just to kind of reframe this, we're making history. This is not something that anybody has seen in 100 years. And what we are dealing with now, and the scope and the level and the response for this is really unprecedented. So, as I said, in some ways, it's a little scary because we really are building the plane as we're flying it, but we are in this together. And I think as not only COVID Command and the city and county of San Francisco and the Department of Public Health, but really all of us as San Franciscans coming together and watching out for our fellow, for our neighbors, and helping to, if there are concerns, if there are groups that don't feel comfortable coming to get access, like really sharing that information and helping us to all work together to make sure that anybody that wants this vaccine can get it and that we get out of this. So I think, this is going to be a point, and I'm looking forward to that day when we can look back on this and say, wow, I can't believe we did that. Right now we are in the thick of it. But I think, I have so much hope after hearing I've been working in the COVID Command Center since March. So for all of those months, the people that I've met, the amount of self-sacrifice and really just community, people coming together to work on this, I have a lot of hope that we are going to be able to get through this together. But it really does need to be all of us working together on this. And so if there are ways that we can support each other or work together, I'm very, very interested in hearing that. And with that, I think I will finish and go on to some questions.
Dr. Tanner, thank you so much. I mean, this has been a blessing. Your presentation has been comprehensive, it's been informative, and it's been clearly stated. And you are truly a blessing to San Francisco and to us today. We're thankful for you and all the work that you're doing, and we pray for you. When people look at the religious community in San Francisco, there are 800 communities of faith and religious institutions, not just the congregations, but also our judicatories, our academic and healthcare institutions that are religiously based, but also the faith-based social service agencies that really provide the safety net for San Francisco's most vulnerable residents. We ask them because they are really frontline, boots on the ground folk dealing with the most vulnerable in our city. If they would pose some questions to you, and I will ask them on your behalf. You've covered a lot of it, but these are nuanced and thoughtful questions, and so I'll begin now. The first is from Hallie Barron, Associate Director of the Jewish Community Relations Council. There's a great concern about the long-term effects of the vaccine. Since only a few months have passed when people have been in the clinical trials, how will recipients be tracked to monitor long-term effects?
Thanks. Yeah, I think that's a really thoughtful and really important question. So one of the ways that we are working to try to track and to keep up with patients is through one of our, it's called our emergency medical database. So that's our electronic health record. So we use Epic, which is just a brand of type of health tracking system, but the vaccine information goes into your normal chart. So if you come to a site, you get vaccinated, your primary care provider will see that in the chart. If you go to an emergency department and they use that same software, they will see that in your chart that you have that. And then there are several different registries within the state where we actually are required to report any potential vaccine related side effects or complications. So that also goes up to the state, and then there's a federal registry as well. So, one of the things that is sometimes challenging within healthcare is that I may see a patient who has an unusual symptoms, for example, and I say, that's a little bit strange. I know that they just got the vaccine. I'm going to put it in their chart, but I may only see one of those patients. But across San Francisco, we might see, say, 10. And across California, we might see 100. And then that goes up. And then that gives us information on whether, if there's something that we did not anticipate. I think the reassuring thing for this, everybody is concerned about getting new medications or vaccines or pharmaceuticals. It's always a little nerve-wracking when there's something we haven't ever done before. What I will say is I personally was really impressed at the number of patients that have been enrolled in these trials. It's 70,000 people already that have received the vaccine. Now, when you're talking about vaccinating millions, there are some rare things that may pop up that we may see as we're moving through. But we are tracking that very closely and making sure that if there is something like that comes along, that we know about it early. It's always a risk, but I think the reassuring thing is that we know how to do vaccine trials. We've done a lot of them over the course of humanity, and with a lot of great success. Working in countries that don't have access to vaccines, I have seen all of the vaccine preventable diseases that we don't see here in the US. And I can tell you that I am kind of a vaccine junkie. Every time I travel, I want to make sure that I've got all of the vaccines that are covered. So I think for this one, it's always a little nerve-wracking, but we are following our normal standards. We have a lot of review around this. And so I think that is reassuring to me.
The next question is from Tom Briotti, President and CEO of the Institute on Aging. Assuming that San Francisco will not have access to sufficient vaccine in the next few months to vaccinate everyone, how should frontline community-based workers be prioritized with the vulnerable individuals for whom they care?
Also another excellent question. So what we are trying to do within the prioritization scheme, so I know that the CDPH and the CDC are doing this, but we are also doing this in San Francisco. Are thinking through what is your level of exposure? So for example, I am an emergency department physician. I work at San Francisco General. My last shift was a week ago, and I saw at least 6 people with COVID. And I was looking in their mouth and, listening to their lungs. And so we know that level of exposure. But for example, we have several testing sites where we have community-based organizations who are swabbing people who are maybe symptomatic for COVID. So they're also doing the same thing. They're wearing the same PPE I am. They're also looking in the mouth and swabbing the nose and the mouth. So those groups also have a high level of exposure. And so we are considering them within the same ranking as the healthcare workers that are providing those services. So I think as we're thinking through this, we're really looking at what are people's individual level of risk, following that prioritization structure, but within that, who is doing what. So the distinction is not so much whether you are a Department of Public Health staff member, or you are a UCSF staff member, or you are a community-based organization. For example, Health Right 360 does a ton of health work as a community-based organization. So those three may have the same level of exposure. They should have the same level of priority. So that's how we're trying to approach this.
Okay. Hilma Meneses, the Chief Executive Officer of Catholic Charities of San Francisco, Marin, and San Mateo asks, Catholic Charities supports inoculation against COVID-19. How can we and other nonprofits support and host a vaccine site similar to what we are doing by hosting a COVID-19 testing site?
So first, thank you. This makes me so happy to hear. I really appreciate that that statement. And so at this point, right now we've been planning for this, like this phase 1A, which is going to be a very limited number. Again, we have 12,000 doses. We have about 50,000 healthcare workers in San Francisco. So as we move out to that phase 2, where we really are ramping up, we are going to need a ton of help. So I think as our team is forming and trying to anticipate the next level, what I think the best thing to do is we're trying to develop a kind of like a community advisory board. So how do we think through this, and how can we best use our community resources to support this? So if it's okay, we just established a new email address, and I honestly cannot remember the exact spelling off the top of my head. So if it's okay, can I send that in?
Absolutely. We'll send it out with the recording link. That would be wonderful. Nancy Nielsen, Deputy Director for Lutheran Social Services, asks, once someone is vaccinated, what should they expect in terms of any limitations, changes in their behavior? Should they keep wearing a mask? Do they still need to be careful about social distancing? What will be possible for a family to all be, will it be possible for a family to all be vaccinated at the same time?
Also really good questions. I really appreciate you thinking so much about this. Like I said, this brain trust is very helpful. So the question around masking and social distancing is a really good one. So I would say at this point, as we mentioned before, we don't necessarily know the duration of time that this vaccine will be effective. We are hopeful that it will be long-term immunity, but we are not sure. And we're also not sure what's going to happen. So as a quick segue, so for flu, for example, we have to get vaccinated every year. We have to do that because flu changes its clothes every year. So it changes how it's harder for the body to recognize it. And so we have to give a new vaccine to really prime the body to recognize it. We don't know if COVID is going to be like that, or if COVID is going to be something more like measles, where you could get vaccinated as a child and you're good. So until we know a little bit more about that, we're going to need to continue to do the masking and the social distancing. I think as we learn more, I mean, all of us, I think I have like a scratch here from my N95 from my last healthcare, my last shift. We're all ready to not have to wear the masks. And I haven't seen my family in a year and would give anything to give them a hug. But until we know a little bit more around this, I think we have to be careful, and we have to make sure that we are not spreading. So that information will be forthcoming as soon as we know something, but it's unknown right now.
The next question is from Mario Paz, Executive Director of Good Samaritan Family Resource Center. I think you might have covered some of these points, so we can quickly go over this. One follow-up question is regarding vaccination access to vulnerable communities. Are there plans to use or partner with trusted community-based organizations and social service agencies to both educate the community on vaccine safety and help distribute the vaccine to vulnerable populations?
Yes, that's going to be really important.
Excellent. Okay.
Yeah, I could talk. I mean, yes, we're hoping. So we have pulled together a community engagement group, and that group is newly formed, and so we'll be reaching out, and we would love to have community input. We need to make sure that we get this right.
And we're glad to invite you to speak directly with the CEO roundtable of this group, because I think that they'd be a great resource for the city. The next question comes from the Reverend Trent Thornley, Executive Director of the San Francisco Night Ministry. Will the residents in SROs and congregate shelters be prioritized for vaccination? Given the low rate of transmission for people living outside, we are a little less concerned with getting these folk to the front of the line, but people living in SROs and shelters seem to be in a different category in terms of risk transmission.
Yeah, so the shelters are absolutely in a different, those are going to be prioritized. The SROs, it really depends on the type of SRO. So if you have, you know, if somebody is in a room and a bathroom for those areas, then again, we have to see what the prioritization, how granular it gets and what the scheme looks like. But yes, anybody that's in any kind of communal or congregate setting is at higher risk, and we want to make sure that we vaccinate those people and everybody that has medical conditions that make them vulnerable to COVID.
Excellent. The next question comes from Marvin White, the Minister of Celebration at Glide, and you know what services Glide is offering. He offers several parts here, so I'm going to go through one by one, okay? I think because I think each one of them deserves some attention. How is the spread of COVID eased or increased when only certain parts of the population have received the vaccine?
So also a really good question. So I think we've all heard about herd immunity, and that, first of all, is not an appropriate strategy without a vaccine. But herd immunity is what we're actually trying to achieve with a vaccine. Because with a vaccine, what we can do is, if you think about, you've got, 5 different people here and you're in the center. These 5 people, if you have a vaccine, if you have COVID, these 5 people could all get COVID, okay? And then if you have other people out here, they pass that COVID on. If this person has COVID and all 5 of these people have a vaccine, these 5 people or 20 people may actually not even be exposed to COVID because these 5 people didn't get it to pass it on. So even a small number of people vaccinated can start to have an impact on the curve. Obviously, we won't see a full impact for a long time, but as we are rolling out the vaccine, that can really help.
The next question is a great one. I've been thinking about this too. Will there be a vaccination ID card? I've been vaccinated that allows certain people to resume their regular lives.
Yeah. So this is actually there's a lot of debate over this because there will be a card that you will get when you are vaccinated. Some countries have started requiring documentation of either vaccine or, there's only a couple people that have vaccine, but have put that in as either vaccine or infection. There is a lot of concern around that because cards can be traded, they can be sold, it can be hard to track that. It also can, you could start to see businesses not letting people come in to sit at cafe counters if they don't have a card. And if you lost your card, there's a lot of risk around that. So we don't know. I think that's still something people are thinking through because obviously there are some benefits to knowing if people are vaccinated or not, but we also don't want to have any of the unforeseen side effects of that. And also at this point, while this is an emergency use authorization, an emergency use authorization means that not all of the studies have been completed, but it is the studies are strong enough to say that this should be given out. But while a vaccine is in an emergency use authorization and not fully authorized by the FDA, we can't require it anywhere because it's still considered too early to require it. So that won't happen for a little while.
I'm going to lump the next 3 questions into one. How's that? Are people who get the vaccine invincible to COVID or still vulnerable? When does the vaccine start working in the body? And with the speed at which vaccines were created, are there implications for vaccines on other viruses?
Yes. Okay. Great questions also. So one, I have this image of the force field around, and I wish that were what it looked like. We don't really know. So for some vaccines, like polio, for example, or measles, the vaccine actually prevents you from getting the disease. For vaccines like flu, you may still get the flu with a flu vaccine. It'll just be more mild and is less likely to kill you. So we don't really know where this vaccine is. With the efficacy rates that we're seeing, it may be on the preventing COVID, but we don't know. And that's another reason why we want to make sure that people wear masks and socially distance, because you may not get that sick, but you might be able to pass it on to your grandmother, for example. So, so we're not sure about that. How quickly it works in the body. So it usually takes a couple of weeks to really get that immunity going. And that's part of the reason we do vaccinations, because our bodies sometimes can be a little slow to respond. So by vaccinating, you're priming the body so that it responds much faster. When we get to that, that 2 to 3 week second booster, usually a couple of weeks after that, we see more immunity. Now, that varies and it can change with different vaccines. So we'll have to do more studies to know for sure. But I would say within about 6 weeks of getting the vaccine, we think that you might start seeing more of an effect. But there's a lot that we need to learn about this. So that's more of an educated guess than a scientific fact.
From the chairman of the board of the San Francisco Interfaith Council, Kaushik Roy, who is also the executive director of the Shanti Project, he asks, many individuals from the most marginalized communities in San Francisco have a great mistrust of the established medical system, and for good reason. Some of these groups have also been hardest hit by COVID. How is the city going to address their concerns that the vaccine isn't safe or can't be trusted? For example, will there be educational campaigns or resources for safety net nonprofits to offer guidance and support to their clients?
Yes, thank you for bringing up this really important question. This is something that we're all very concerned about. And you're right, there is really good reason. The scientific community has made some terrible, terrible mistakes in the past. And I think, people are skeptical. And so yes, what we really want to do is to bring the information as we're getting it, it's a little slow in coming, but as we're getting this information, to bring it out to the public and to bring it out to, especially to trusted leaders within the community, to really be able to take a look at that and to be able to talk their fellow community members and constituents into talk them through what the information is and help them to make a decision. Really with this kind of an effort, we want to make sure people have the information and that they can make a decision that is well informed. We don't want a population that has been highly vulnerable, has been hit hard by this disease, not getting something that is potentially life-saving because they don't trust where it came from. At the same time, we don't want that same community to feel like they're being pushed into something that they don't want to do because they're not being given the information. So I think, and this is where I think we're also going to need help because I'm as guilty as the next doctor. Sometimes I forget, I go into medical speak and I forget that, that I'm saying something that maybe people aren't understanding, or I'm not being clear about how I speak about this. And so I think understanding what people's concerns are so that we can do the research and address that. And then 2, translating that into information that makes sense to people. So that they can, again, think through it and make a decision for themselves. It's going to be really important. So I'm really looking forward to that partnership because that is an area that I think public health professionals around the world need help in. It's something where we have to really partner to make sure that we're putting out things that are understandable and needed by the communities.
The COVID Command Center has been convening what's called the faith-based roundtable. And out of deference to them and gratefulness for their support of these programs, the last 3 questions are going to come from their team, okay? The first is, do you have any idea if the vaccines are one-time or annual periodic treatments?
Yeah, we don't know yet. So that's something we're going to have to see as we learn more about the immunity.
The next question comes from Archbishop Cordileone of the Archdiocese of San Francisco, who also serves as chairman of the board of Catholic Charities. Will COVID testing remain a priority for the city after vaccines become available to the public?
Yes, absolutely. We need to know. I think in some ways it's even more important because we need to know what is happening within the city. Are the vaccines effective? So one, are the vaccines effective? Two, are people actually getting the vaccines? Because if we see, for example, to go back to Mr. Roy's question, if we are thinking about, if we start to see a big surge in cases in a particular community, it may be that that community elected not to get the vaccine. And so we need to understand what the reasons are, if we can help support them with information, and if they still don't want to get the vaccine, understanding that that particular community is going to be vulnerable. And so we need to try to make sure that they have the resources and support to try to continue social distancing, masking, and getting healthcare if they get sick. So I think the testing is really going to be important for us.
Excellent. And the final question, will the vaccines be available and effective for kids and young children?
Also a really good question. The way that they do vaccine studies is they always start them in adults, because there's a lot more, obviously, adults can give informed consent. They can say, yes, I know I'm in a study and I want to be in the study, where children cannot. So when we want to make sure that things are safe, initially in adults, and then they start expanding to other groups. So there are, one of the vaccines that is in trials right now has expanded to, I think, kids, I want to say down to the age of 12. So they haven't done young children yet, but they have expanded based on safety data. There are also some that oftentimes the older adults are not included. So these trials are starting to expand out as we, even these vaccines that have already submitted for the emergency use it's hard for me to say that early in the morning, emergency use authorization. The ones who have submitted for that will continue to do studies so that we can understand the safety data. So for example, in children, in older patients, and also in pregnant women. The pregnant women are generally excluded from studies as well. So those groups we will be learning more about, but it's less likely that it may take some time for us to know more about that.
Dr. Tenner, I have to tell you, when we were planning the series of programs, we didn't realize how timely your presentation would be. We are very, very grateful for the time you've given us, the expertise you've given us. And I want you to know that the recording link of this is going to be sent out to the San Francisco Interfaith Council's 5,000 e-subscribers by day's end today with your slide deck and any other helpful references, links, or email addresses that you feel would be helpful. We are grateful. We're also grateful to Kaushik and Rinso Ed Sadazan for their participation. I would be remiss if I did not say a very special thank you to San Francisco Interfaith Council Administrative Program Associate Cynthia Zambucas, who has really just been so helpful in making sure everything gets done, as well as to the COVID Command Center's Joint Information Center Virtual Outreach Team, John McKnight, who oversees that Joint Information Center, as well as coordinator Trey Russell Allen, our producer today, Elisa Karawali, and leads Sharon Walton, Hafisa Salabai, and Nick Marino. We would encourage you all and to please join us next week as we take up the very timely issue of court rulings on government orders to limit the number of congregants who can enter houses of worship for worship during this time of pandemic. We have a constitutional law professor from the University of San Francisco who will be our featured presenter, and it should be a very timely as well and helpful presentation. With that, today's program concludes. And again, thank you to all, and we look forward to seeing you next week.
Thank you, Doctor.